Is Andrew Stokes, who is a professor in the School of Public Health. And he's going to talk about machine learning analysis of factors associated with semaglutide initiation among adults with obesity. Andrew.
Thank you very much to Yannis for hosting this event together with the CTSI. I think what you're doing, bridging the divides between the Charles River campus and the medical campus is very unique and important and has a lot of potential for innovation and applying the best practices in computing and machine learning and artificial intelligence to medical problems. I also want to thank Dr. Perlis for a great talk. Today I'm going to talk about a new JAMA Network Open paper that we've just published. So thanks again for your service to the journal. This is a paper where we've looked at the factors associated with semaglutide initiation among adults with obesity. And the broader problem here is that I want to frame today is how do we use large unstructured administrative databases together with AI and machine learning tools to generate insights where we may not have a lot of a priori theory about what's driving take-up trends. So the kind of the case study today is around these novel GLP-1 receptor agonists, which have been in the news a lot lately. Here we're going to focus on semaglutide, which is popularized through the formulation of Ozempic, initially designed to treat diabetes, but recent clinical trials concluded that they are highly effective at weight management and CVD prevention, leading to FDA approvals for other indications. The population that we're going to focus on today is a population that's often left behind, which are those that are often deemed metabolically healthy, but still have elevated weight status. So those with obesity without diabetes. And we're going to characterize current users of these medications without diabetes to understand how to provide effective care to those in need. So the overarching objective is to take all of this data that we have in claims and try to construct a reasonable prediction model to understand what's driving take-up patterns in this landscape where there's huge inequities in access. Clearly, some populations are getting these drugs, others are not. Ozempic, when it first came around, was being used in Hollywood, but those who really needed it were not getting it. So that's kind of the driving question. And the challenge is that with these administrative databases, whether it's claims or EHR data, we capture billing data submitted by healthcare providers for services, including diagnoses, procedures, and medications used for reimbursement purposes. But these were not developed for research purposes, and the data are often complex to clean and analyze. So the challenge is to develop a meaningful and accurate predictions requiring parsing thousands of data elements, and in doing so in a way that also reveals what's driving those underlying predictions and what are the meaningful determinants, which is often hard to do in an AI or a machine learning environment where the underlying predictive factors are often pretty black box. So predictive modeling with machine learning offers a flexible and data-driven approach to prediction in the presence of thousands of potential features. I think such approaches are especially valuable, again, where we don't really know a priori what the most relevant predictors are. And today we're going to kind of use last century machine learning approaches, but with the hope, together with CTSI and Hariri and all of you, thinking about how do we take these language models and kind of recent innovations in the space to improve upon these predictions. So the basic design for our claims and EHR-based analyses is to kind of create an index date around new obesity diagnoses. So we look at people who've come to the physician with a new diagnosis of obesity, and then we look at the 6-month period following obesity diagnosis to see whether they took up semaglutide, whether they were prescribed semaglutide in claims data. And we use kind of a 12-month washout prior to the E66 diagnosis to evaluate over 1,000 potential features that could be predictive. And we exclude those with other metabolic conditions like diabetes because we're interested in this kind of left behind population of those with obesity but without diabetes. We're using random forest and we're using mainly using the machine learning step for feature identification to take this kind of list of 1,000 or more features and do some dimension reduction and identify some of the most relevant predictors for analysis. We use Shapley additive explanation methods to visualize and understand the contribution of each factor to the predictive models. And then we combine this with a kind of a simple causal
inference step to then understand in kind of a multivariable model which of these identified predictors are most relevant. Here are some of our predictor classes. We take multimodal data from demographic, geographic, and enrollment variables. We take diagnostic variables, and we take medication variables. And these come from different crosswalks and summary measures, including these 480 CSR categories and these 190 Red Book therapeutic classes for drugs. So this is the basic table from the paper just published in JAMA Network Open. We have a sample of about 100,000 individuals, of which about 2,000 initiated semaglutide. So over this period, semaglutide uptake is still quite rare because this kind of captures the early period in which semaglutide was rising at the population level, but it hadn't really taken hold yet. So in claims data, the performance of the predictive modeling is moderately good, but not great. Here we get an ROC AUC score of about 0.71, something that we hope to improve on with other data sources. And we use a SHAP plot to kind of visualize some of the underlying factors that inform the prediction. So among the top 20 most important variables identified by the random forest classifier model, some of the basic demographics were important, as well as some of the medication classes. For example, those who take antidepressants or have seen a psychiatrist are much more likely to take up semaglutide than those who are not prescribed antidepressants or seen psychiatrists, reflecting some of the multimorbidity or comorbidity between metabolic conditions and psychiatric conditions. So here's the kind of the inference step where we put this into a multivariable model. And one of the variables that we model is just a simple time trend, which kind of shows that the take-up increases from 2021 through 2022. And then there's this period where there were shortages and take-up goes back down. And then we've just started to add 2023 data, which shows it going way back up, but with some substitution effects with tirzepatide now taking over from semaglutide. Individuals taking adrenal medications, thyroid medications, antidepressants, or amphetamines prior to their initial obesity diagnosis were more likely to initiate semaglutide within 6 months, with antidepressants having the highest odds ratio. So clearly some overlap and multimorbidity being reflected here. Some of the plan types were more likely to translate into take-up with EPO and HMO plans, the least likely to initiate semaglutide with 6 months, reflecting the constraints of those health plan types. Some key takeaways: in a large sample of commercially insured individuals with obesity and without diabetes, we identified demographic, healthcare, and clinical factors predictive of semaglutide initiation within 6 months after obesity diagnosis. We integrate common medications, insurance plan structure, employer industry type, and gender as significant factors associated with uptake. And we think that these findings suggest that inequities persist in medication access in this understudied subgroup, and further research should investigate factors predictive of GLP-1 medication use in those on public payer plans, as well as those concurrent use of common medications impacting real-world effectiveness. So this work is all based on employer-sponsored insurance data. There's a real need to study this in Medicare and Medicaid populations and in those that may lack insurance. More generally, we think that administrative claims data are complex and multidimensional and require computational approaches that can automate the search for associations. In the case of emerging treatments such as novel GLP-1s, predictive modeling provides a flexible approach to analyzing thousands of potential features where a priori identification of key features may not be possible. And we think that these ML-based variable selection approaches are complementary to traditional causal inference and should be combined wherever possible. So there's kind of this machine learning step or AI step that's combined with causal inference to identify causal patterns. These are my collaborators. This work is funded by the Robert Wood Johnson Foundation, and thank you for your time.